let's talk about a very important topic. And the reason why I'm calling it important is because these are the topics which students usually neglect. They are towards the end of the surgery modules, and you tend to neglect these chapters. And if an MCQ comes from this, you are caught in the wrong position, right? So that is why it is important that you quickly listen to these modules on thorax and mediastinum and skin and soft tissue tumors. Because if you get a question, then your rank can jump much higher above others because they would have probably missed out on these fringe modules. Okay. So before we discuss about the conditions of thorax and mediastinum, let's talk about the relevant surgical anatomy. So we know that the right lung has 3 lobes. You have the upper, middle and lower lobe, whereas the left lung just has an upper and a lower lobe. Now the importance of knowing this is that the bronchi on the right side, the right mainstem bronchus is straighter. The right mainstem bronchus is shorter and straighter. And so the advantage of knowing this is that if there is a foreign body inhalation or if there is aspiration, remember we spoke about achalasia, we spoke about Zenker's diverticulum. If there is aspiration or if a foreign body is inhaled, then it will preferentially go towards the right side because it is a shorter and a straighter bronchus. And when it goes on the right side, there are 2 segments where lung abscesses will be common. So post aspiration, lung abscesses are common. Post aspiration, lung abscess is common in the posterior part of the upper lobe of the right lung and the apical part of the lower lobe of the right lung. So 2 segments can commonly get involved with lung abscess when there's aspiration. One is the posterior segment of the upper lobe of the right lung, and the other one is the superior or the apical segment of the lower lobe of the right lung. These are the 2 most common segments where abscesses can form post-aspiration. This you should know about. So the other thing which you need to know is regarding the lymph nodes in this region, and again these lymph nodes around the lung have been divided into various stations. Now if you remember gastric cancer, we've discussed that there were multiple lymph node stations there as well, and they were useful for staging and also for resection of the tumor. Similarly, these help in staging and in removal as well. You should know that N1 lymph nodes are N1 are 10 to 14 lymph node stations. So lymph node stations number 10 to 14. So hilar, interlobar, lobar, segmental and subsegmental. These are N1 lymph nodes, whereas N2 lymph nodes will be 2 to 9. So 2 to 9 stations are N2 lymph nodes. So this is how it helps us in classifying these lesions or lung cancers. Again, this has not been asked, just for your information. This has been written in Bailey, so I wanted you to know. Foreign body in a bronchus, I've already told you, it is more common on the right side as compared to the left side. More common on the right side as compared to the left side because the right bronchus is shorter and straighter. The clinical features, the patient can be asymptomatic. Or the patient can come with wheezing, or the patient can come with stridor, or there can be a collapse of the lung as well. These are the various features in a patient with foreign body. You can see the foreign body on an X-ray or a CT. You can see the foreign body, and the management of these patients is bronchoscopic removal. Of the foreign body. Now, before we talk about other conditions in thoracic disorders, I want you to know about thoracoscore. So this thoracoscore tells us about the mortality, following thoracic surgery or lung resection. So thoracic surgery, when you're opening up the thorax, it's a major procedure, and post opening up the thorax, there can be morbidity and mortality, and to predict that we can use thoracoscore. Now thoracoscore takes into account 9 parameters. So takes into account 9 parameters: the sex, ASA grade, the performance status according to the Zubrod scale. If you remember in the clinical case discussions which I've covered, I've spoken about Karnofsky score and ECOG score also in performance status. Here the Zubrod score is being considered. Severe dyspnea, priority of surgery, extent of resection, diagnosis, and the comorbidity score. And the 9th parameter is age. So these are the parameters which are included in the thoraco score which you should know about. Now, one more thing which is written in Bailey which you should know is that post-surgery, FEV1 and diffusion lung capacity. So forced expiratory volume in 1 second, and the diffusion capacity of the lung. These are the two predictors. For dyspnea following lung surgery. So after surgery, these two are the major predictors which are used to predict whether the patient is going to develop dyspnea or not. And prior to surgery, we look at the thoraco score, and that will tell us the risk of mortality if this patient undergoes thoracic surgery. Now, this thoraco score was asked in the NEET exam, so you should know about it. You should know that there are 9 parameters which are included in the thoraco score. Now, the next condition which we need to talk about is pneumothorax. Now, I want you to know here that in thoracic trauma, I have already covered traumatic pneumothorax. So I'm not going to cover it here. I have covered tension pneumothorax, which is very important for the exam. That has also been covered in thoracic trauma. Also in thoracic trauma, I've covered about chest tubes. So please refer to that module to know more about tension pneumothorax and chest tubes and traumatic pneumothorax. What I'll be covering here is spontaneous pneumothorax. Okay. Now, spontaneous pneumothorax can be of 2 types. You can either have primary spontaneous pneumothorax, and primary spontaneous pneumothorax means, so pneumothorax we already know is air in pleural space. So we know pneumothorax is air in the pleural space, and primary spontaneous pneumothorax is seen in young patients. Males more commonly affected than females, and these are usually tall, thin males, and these people usually have a family history present of this condition, and there are blebs in the upper lobe, usually in the upper lobe, and when these blebs rupture, that can give rise to pneumothorax. Now, these patients are usually fit patients, so they tolerate pneumothorax better. Okay. Secondary spontaneous pneumothorax is secondary to underlying lung disease. So in primary spontaneous, there wasn't any underlying lung disease. Okay, in primary. Secondary can be secondary to tuberculosis, tumors, or emphysema. This is usually in elderly patients, and pneumothorax is less well tolerated as compared to primary because there's already a lung pathology which is present here. So if there is pneumothorax, these patients don't tolerate it as well as primary. Okay. Now, primary spontaneous pneumothorax, a very common example is pilots. And there is an incident which one of my friend who's a pulmonologist told me, that he was traveling for an international conference, and during the flight, one of the reserve pilots who was there, he developed breathlessness. And they declared it a medical emergency and they called a doctor. So my friend attended to him and found out that that was the first episode of primary spontaneous pneumothorax in that person, and he had to put in a needle to decompress that pneumothorax during the flight. Now, the clinical features of pneumothorax, when this develop, the patient is going to come with sharp pleuritic pain. Now, when there is partial collapse, there is less dyspnea, but there is more pain because the parietal pleura rubs over it. So there is more pain when there is partial collapse. But if there is complete collapse of the lung, there is more dyspnea. Of course, because the entire lung is not working, there is more dyspnea, but it is absolutely painless. So complete collapse would be painless. We know on examination, whenever there is pneumothorax, we will get a hyper-resonant percussion note. We will get a hyper-resonant percussion note in these patients, and we will get decreased air entry. There will be decreased air entry on that side and decreased breath sounds on that side as well. Now we can do a simple X-ray to see whether pneumothorax is present or not. A simple X-ray can be done in these patients. Now patients who develop spontaneous pneumothorax once are always at risk of developing pneumothorax in future as well. So the risk of recurrent pneumothorax also you should know about. Those who experience the first episode, approximately 1/3 will experience recurrence. Those who have it second time, 50% will develop a third episode as well. And if they've developed a third episode, then 100% they will develop multiple episodes in future as well. So this also helps us in directing the management in these patients. Now the management of spontaneous pneumothorax, if it is primary spontaneous pneumothorax, if patient is symptomatic, then we will carry out aspiration of the pneumothorax. We will do aspiration of pneumothorax. Otherwise, in majority of the patients, primary spontaneous pneumothorax is self-limiting. Otherwise, it is self-limiting. Now, if it is secondary pneumothorax, all patients will require aspiration, right? Because it is already secondary to a lung pathology and it is less well tolerated. So everyone will require aspiration. And if condition does not improve, then we have to put in a chest tube in the triangle of safety. And this is usually a narrow bore chest tube which is put in the triangle of safety. Triangle of safety I've already covered in thoracic trauma. I've told you about triangle of safety there as well. Just to recapitulate triangle of safety, it is bounded anteriorly. Anteriorly, you have the anterior axillary fold. Which is formed by the pectoralis major. Posteriorly, you have the posterior axillary fold, which is formed by the latissimus dorsi. And base is formed by the fifth intercostal space, forms the base. Apex is in the axilla. And this is our triangle of safety, which we've discussed in patients with thoracic trauma as well. Now, what are the indications for surgical intervention, right? So initially we try to manage these patients conservatively, but if the patient is not responding, we have to carry out a surgical procedure. And the indications for surgery in pneumothorax, if there's a second ipsilateral pneumothorax, first contralateral pneumothorax, okay? So second ipsilateral means the second episode has developed. And I told you if the second episode develops, there's a 50% chance that the person might develop a third episode as well. Contralateral pneumothorax puts the person at risk of developing pneumothorax on either side. So there also we have to carry out surgery. So if there's bilateral spontaneous pneumothorax, if the pneumothorax fails to settle despite chest drainage, if there's spontaneous pneumothorax in at-risk individuals like pilots and divers, right? So if you have pilots and divers where pneumothorax has developed, you don't want it to develop again during mid-flight. It can be dangerous. So these patients also require intervention there. And pregnancy as well. So these are the indications where we need to carry out surgical intervention. Now, surgical intervention these days is usually done using either the open method or VATS. And what we preferred is VATS. VATS is preferred. VATS stands for Video Assisted Thoracoscopic Surgery. VATS is Video Assisted Thoracoscopic Surgery. So video-assisted thoracoscopic surgery is done in these patients. And when we are doing video-assisted thoracoscopic surgery, we use a double lumen endotracheal tube, we use a double lumen endotracheal tube. Now, what is the advantage of a double lumen endotracheal tube? The advantage is that we can collapse one lung. So the site where we have to operate, we will collapse that lung and we get space to operate there. So unlike laparoscopy, which we discussed in minimally invasive surgery, unlike that, here I don't need to insufflate air in the thorax. I just need to collapse the lung and I will get working space. Okay, so you can see this is video assisted thoracoscopic surgery, and when we are doing video assisted thoracoscopic surgery for pneumothorax, when we are doing it for pneumothorax, what do we have to do? We have to control air leaks. We have to control or repair the air leaks. We have to resect the blebs so that they don't rupture and they cause pneumothorax again. And we have to carry out pleurodiscs. Pleurodiscs is that you know that there are two layers of the pleura. You have a parietal pleura and a visceral pleura. So pleurodiscs means we are going to make them stick together. And if they stick together, then pneumothorax will not develop. So pleurodiscs can be done using talc or tetracycline. So talc or tetracycline is going to induce inflammation inside the pleura and it leads to the two layers sticking together, pleurodiscs occurring. It is extremely painful, right? We use this in our cancer patients who develop malignant pleural effusion, right? So ultimately we have to do pleurodiscs, otherwise they'll keep on developing it again and again. So there, through a chest tube, we put in talc or tetracycline, but it is extremely painful, which is why we have to give adequate analgesics in these patients. We can strip the pleura. And that also helps in these patients. That's called pleurectomy. That can also help in these patients. So this was the management of primary spontaneous pneumothorax. I've already covered tension pneumothorax and traumatic pneumothorax in thoracic trauma module. I just want to summarize primary spontaneous pneumothorax. This is a flowchart which is given in the latest Bailey. So if there is spontaneous pneumothorax, if patient is unstable, we proceed with chest drain insertion. If the age is more than 50, smoking history is there, evidence of lung problem is there on X-ray or examination, then it is classified as secondary pneumothorax. If none of these are there, then it is primary spontaneous pneumothorax. Now, if primary spontaneous pneumothorax is more than 2 centimeters and or breathlessness is not present, so less than 2 centimeters, no breathlessness, we discharge and we call in the OPD after 2 to 4 weeks. But if the patient is breathless or it is more than 2 centimeters, then we aspirate using a cannula. And if the patient improves, we discharge the patient. If it is secondary spontaneous and the size is more than 2 centimeters, then we are going to proceed with the chest drain insertion in secondary. If not, then we are going to aspirate. And if the aspiration is not successful, we will again insert a chest drain in these patients. I've already told you chest tubes are put in the triangle of safety. This is the chest tube. I've demonstrated this in the thoracic trauma module in great detail. And you should know that chest tubes are connected to underwater seals. They are connected to an underwater seal bag. This also, the significance of this underwater seal bag, I have covered in the thoracic trauma module. Hemothorax is accumulation of blood in the pleural space. This has also been covered in the thoracic trauma module. So I want you to watch the thoracic trauma module as well for details. The next condition which we need to talk about is empyema. Empyema is accumulation of pus in the pleural space. There is pus in the pleural space, and first you should know what are the causes which can give rise to empyema. So empyema of the lung, you can have pulmonary infections like unresolved pneumonia, tuberculosis, which is very common in our country, fungal infections, lung abscesses. There can be aspiration of pleural effusion can give rise to infection. Trauma, that means any injury or esophageal perforations. There can be a subphrenic abscess or a liver abscess which can rupture into the lung and can give rise to empyema. So you can have a right lobe liver abscess which can rupture, and that can also give rise to empyema. Or bony infections like osteomyelitis of the rib or the vertebrae can also predispose to empyema. There are 3 phases of empyema which you should know about. These have been given in Bailey. So you have the exudative phase. In the exudative phase, you have thick pus here. There's going to be thick pus. The patient might be running fever. And the organisms which are responsible are Staph aureus or Streptococcus. This is Staph aureus or Streptococcus. And in this phase, when there is pus only present, there are no lung changes which are present, we have to carry out aspiration. We have to do aspiration plus antibiotics to cover these bacteria. That is what needs to be given in this exudative phase. So aspiration and antibiotics. The second phase is the fibrinopurulent phase. So as the name suggests, that some amount of fibrosis will start occurring in this phase, right? So there is thickening of the pus. There is thickening of pus and the pleura, right? Thickening of pus and the pleura, and aspiration can become slightly challenging here. So aspiration can be challenging here, but it has to be done, and antibiotics have to be given. Okay, and antibiotics have to be given in these patients. Finally, you have the organized phase. Of empyema. So in the organized phase of empyema, there is thickening of the pleura, there is further thickening of pleura, and the lung becomes entrapped. Right, so the pleura thickens so much that the lung cannot expand only now, right? Lung cannot expand. So expansion is limited. That would also give rise to dyspnea in these patients. Aspiration is not possible here. Aspiration is not possible in these patients. And we have to strip the pleura. Or we have to carry out VATS, video assisted thoracoscopic surgery, to drain the collection, to drain pus, and to release the lung, so that the lung can expand. So in severe cases, if this is not working out, we have to carry out decortication. We have to remove the entire pleura. So that entrapment of the lung goes away. So that is how we manage a patient with empyema. And if you do imaging, so you can see on CCT. On CCT, you can see the imaging here, and you can see the collection. Sometimes there can be loculi in these collection, which is why if you put in a chest tube, it will only drain one loculi, or if you aspirate, it might just drain one loculi, which is why we need to be careful in these patients that all the loculi are drained properly so that it does not recur. So this was regarding empyema. The next condition which we need to talk about are lung cancers. So lung cancer is one of the leading causes of cancer all across the world, and one of the leading causes of cancer-related mortality. So the survival in lung cancer is not as good as, say, a breast cancer or a thyroid cancer. The risk factors we know are predominantly environmental, like smoking, pollution, exposure to occupational hazards like asbestosis. All these can predispose the patient to lung cancer. So like I told you, majority of the patients with lung cancer present at an early stage. Only 20 to 25% patients are amenable to surgical resection, when they come to us. Otherwise, majority of the patients with lung cancer come with advanced disease. Now, lung cancer can predominantly be divided into two main types. It can be divided into small cell lung cancer. It can be divided into small cell or oat cell. Oat cell was the previous name for small cell. And it can be non-small cell lung cancers. and these can be non-small cell lung cancers. Now, small cell lung cancers have the strongest association with smoking, right? Strongest association with smoking. Males are more commonly affected and they usually carry a poor prognosis. They spread rapidly. The advantage of small cell lung cancers is that they are highly chemosensitive, right? They're highly chemosensitive and they respond very well to chemotherapy. They show the maximum number of paraneoplastic syndromes as well. And we've discussed paraneoplastic syndromes in hepatocellular cancer and renal cell cancer. We need to know the paraneoplastic syndromes in lung cancer as well. The paraneoplastic syndromes can again be endocrine or non-endocrine or neurogenic. So endocrine paraneoplastic syndromes can be Cushing's disease because of ACTH release, SIADH, acromegaly. Neurological can be Lambert-Eaton syndrome. Lambert-Eaton we studied in renal cell cancer as well. There can be cerebral degeneration. There can be opsoclonus, myoclonus, which we've discussed in neuroblastomas as well. Another thing which can be seen in patients with small cell lung cancers is SVC syndrome, is superior vena cava syndrome, which is an oncological malignancy. This is an oncological malignancy, and in SVC syndrome, there is going to be a thrombus in the superior vena cava. So on imaging, there is a thrombus in the superior vena cava, and the clinical features with which patients come to us are facial and cerebral edema. And these patients can also come with hypertension and breathlessness. They can come with hypertension and breathlessness. And on imaging, you will see a thrombus in the superior vena cava when you do a CT. Now, the histopathology of small cell lung cancers is very important. And here, two things which you should know. You get the Azzopardi effect. Which Dr. Ila has covered in great detail in her modules. And this is Azzopardi effect. You can get salt and pepper chromatin. There can be salt and pepper chromatin in these patients. And you should know about the IHC markers. So a latest trend from lung cancer has become these IHC markers for various lung cancers. And for small cell lung cancer, this is chromogranin and NCAM. This is chromogranin and NCAM are the IHC markers which are there in small cell lung cancer. Now, small cell lung cancer, I've already told you, they are highly chemosensitive and we can even use radiotherapy in these patients. But one major thing which has happened in lung cancer, which has improved the survival, is targeted therapy or immunotherapy. So based on these IHC markers or the mutations which are there, selective agents are being targeted and they are prolonging the lifespan in patients with lung cancer. So we've discussed small cell lung cancer. The non-small cell lung cancers, the first one is squamous cell carcinoma. And squamous cell carcinoma, these tumors are usually centrally placed. And they have a strong association with smoking. In fact, these are the most common cancers in smokers. This is the most common lung cancer in smokers. Now, a couple of things in squamous cell carcinoma which are unique. Number one, that this can release PTH-related peptide, and this can give rise to hypercalcemia of malignancy. Which we know is the most common paraneoplastic syndrome. This we've covered in hyperparathyroidism as well. And second, what can happen is the squamous cell cancers can also be associated with Pancoast tumors. Now, Pancoast tumors are tumors which are placed in the apical region. And they can press on the brachial plexus. So you can see here on imaging, you can see this apical tumor here, and this can press on the brachial plexus. This is a Pancoast tumor, which is usually a squamous cell carcinoma, and we know that this can give rise to pain along the ulnar distribution, Pain is mainly along the ulnar distribution, and it can also give rise to Horner syndrome. It can also give rise to Horner syndrome. So Horner syndrome, you know the features of Horner syndrome. You have ptosis, meiosis, anophthalmosis, and anhidrosis. So this is what we get in squamous cell carcinomas. On histopathology, we know squamous cell cancers. You will get keratin pearls, which are a characteristic feature of squamous cell cancers all over the body. So you get keratin pearls. And the IHC markers are cytokeratin and P40 are the IHC markers which are being done for patients with squamous cell carcinoma. Now, squamous cell carcinoma responds well to radiotherapy. So this is a radiosensitive tumor. That is another thing which I want you to remember. The other non-small cell cancer is adenocarcinoma. Now, adenocarcinoma is more common in females as compared to males, and it is now the most common lung cancer overall. It is peripherally placed. Adenocarcinoma can be peripherally placed, and adenocarcinoma can also develop in cavities. Like if there is a tubercular cavity, adenocarcinoma can develop in the tubercular cavity. These are usually slow growing, but they show early metastasis as well. And the new markers are napsin-4. This has been asked in the exam, and mutation is of ALK and RAS mutations are usually seen. Now, one of the tumors which is getting a lot of importance these days is bronchoalveolar carcinoma or in situ cancer. This is in situ lung cancer or bronchoalveolar carcinoma. This tends to be multifocal right? But because it is in situ, it is still resectable. Even if it is multifocal, it is resectable. And the pattern of spread, so the spread occurs along the bronchoalveolar lining, and this is known as the lepidic pattern of spread. This question has also been asked. This is known as the lepidic pattern. It spreads along the bronchoalveolar lining. So this spreads along the bronchoalveolar lining, and this is known as the lepidic pattern of spread, but we can still resect these tumors. So these are the various types of lung cancers which I wanted you to know about. The clinical features of lung cancer, the most common clinical feature is cough. That is the most common clinical feature. There can be hemoptysis as well. Patients can come with pain. They can come with metastasis. And lung cancer is the most common cancer which metastasizes to the brain. So brain mets are very common. And these brain mets are usually symptomatic. But another common side is the adrenal gland. But these usually adrenal gland metastases are usually seen on PET scan. They are not usually symptomatic. We've already discussed that these patients can come with paraneoplastic syndromes. And they can also be Pancoast tumors which can present with Horner syndrome as well. So these are the clinical features of lung cancer. And whenever you get a patient where you're suspecting a lung cancer, the initial investigation which we'll order in these patients is a simple chest X-ray. We can do a CECT can also be done, which will tell us about the tumor. And for staging purposes, we need to do a PET-CT. Now, to confirm the diagnosis, we can either do a CT guided biopsy. A core needle biopsy can be done from the tumor. If a CT guided biopsy is not possible, then we can do EBUS FNA. This is very important. EBUS FNA is endoscopic bronchial ultrasound guided FNAC. So EBUS stands for endobronchial ultrasound, and This is usually present in places which are dealing with lung cancer. They usually have this in their armamentarium. So pulmonologists will do a bronchoscopy and there is an ultrasound probe attached with it. So you do an endobronchial ultrasound and you can do an FNAC from the lesion or from the lymph nodes to confirm the diagnosis. Also, another way to confirm the diagnosis and to get tissue is to do mediastinoscopy. So mediastinoscopy can help in confirming the diagnosis. We can get tissue and it can also assess resectability, to assess whether the tumor is resectable or not. To assess resectability also, we can carry out a mediastinoscopy in patients. Now, lung cancer staging was asked in the NEET exam 2 years back. So you should know the basics of lung cancer staging. And this is the 8th AJCC classification for lung cancer. So TIS is in situ cancer, which I've told you is bronchoalveolar carcinoma. T1 is when the tumor is less than 3 centimeters, surrounded by pleura, not invading the main bronchus. T2 is 3 to 5 centimeters or involvement of the main bronchus without the carina. T3 is 5 to 7 centimeters in greatest diameter and any size that involves the chest wall, pericardium, phrenic nerve or satellite nodules. And T4 is more than 7 centimeters or any tumor which is invading the mediastinum, the great vessels or mediastinal structures. So if the pleura or the chest wall is involved, it becomes T3, and T3 then it becomes a locally advanced disease in patients. N1 is ipsilateral peribronchial or hilar lymph nodes and N2 is mediastinal or subcarinal. I already told you the stations when I was telling you about the surgical anatomy at the starting of this module. N3 is the presence of contralateral mediastinal or hilar lymph nodes. M1 is divided into M1A, M1B and M1C. M1A is tumor in contralateral lung or pleura or pericardium. M1B is malignant effusion and C is extrathoracic metastasis is M1C. Extrathoracic metastasis in multiple organs is M1C. So this one is M1C, multiple extrathoracic, and M1B is the presence of single extrathoracic metastasis including a single non-regional lymph node. So this is the staging. Basic staging was asked. What they had asked in the exam, in the NEET exam, was that given a size and they had said that the tumor is 2 centimeters and there is no lymph node involvement. So they just wanted to know that it is T1N0. That was the question which was asked in the NEET exam. Now, how do we manage these patients with lung cancer? So management of patients with lung cancer, I told you only 20 to 25% patients are amenable to surgical resection. And only those patients who are T1 to T3, N0 or N1, M0. T1 to T3, N0, N1, M0. These are the patients where surgery can be carried out. In all other patients, it is considered as locally advanced and we cannot carry out surgery in those patients. So in these patients, we can carry out surgery. I've already told you how we assess the patient for surgery. The incisions which are usually made are posterolateral thoracotomy. So posterolateral thoracotomy approach is used for lung cancer surgery. And in posterolateral thoracotomy approach, we are going through the latissimus dorsi, the serratus anterior, latissimus dorsi, serratus anterior, the intercostal muscles, and that's when we will enter the thoracic cavity and we then carry out the surgery. We've discussed that anterolateral thoracotomy is mainly used for thoracic trauma and I've already covered it in the thoracic trauma module. Now, the surgeries which can be carried out for lung cancer, we can either do a lobectomy, where just one lobe is removed. We can do a pneumonectomy. Pneumonectomy is when we are removing one of the lungs. And these days, we are also doing sleeve resection. Sleeve resection or bronchoplastic procedures. Sleeve resection or bronchoplastic procedures are also being carried out. This is more conservative surgery which is being done for lung cancer. If it is a very early lesion, then in these patients, we can even do a wedge resection. So this was regarding surgery. This was regarding the surgical management. The other things for managing lung cancer are chemo and radiotherapy. Radiotherapy, I told you, squamous cell carcinomas respond very well to radiotherapy, whereas small cell lung cancers respond well to chemotherapy. I also told you targeted or immunotherapy is also being used for lung cancers, and you identify the mutation and then you try to search for a drug regarding that particular mutation. So that is the management of lung cancer and the various types of lung cancer. I would strongly recommend that you also watch the pathology module on this, where Dr. Ella has shown you all the slides and the IHC markers. I mentioned the IHC markers, but how do they look like on a slide? You can refer to that module for more details. Now, whenever we do surgery, there can be complications of lung resection as well. And I told you at the starting of this module that we use the thoracic score to predict mortality following lung surgery. The complications can be bleeding, respiratory infection, persistent air leak, bronchopleural fistula. These are the various complications which can occur. And whenever we do any major thoracic surgery, the main problem which we have is that the patient, because of pain, will develop atelectasis and can develop dyspnea. So atelectasis, dyspnea, and that can then lead to infections as well. So which is why proper pain control and proper physiotherapy is also required in these patients. Moving on to the benign tumors of the lung. So the most common benign tumor of the lung is a hamartoma. And the clinical features, mostly these patients are asymptomatic, or they can come with cough or hemoptysis. When we do an X-ray, we are going to get a coin-shaped lesion. We either get a coin-shaped lesion or we can get popcorn calcification. That is what we'll see. We'll either get a coin-shaped lesion or we get popcorn calcification. And you can see on this X-ray, let me just show you the X-ray as well. You can see on this X-ray, you can see a coin-shaped lesion, and the management of these hamartomas is excision. And this excision can be done via the minimally invasive route. We can use VATS to carry out excision of this hamartoma. Now, the next thing which I want to talk about is something from which questions are being asked in the last 3 years, and these are mediastinal tumors. So you know that mediastinum can be divided into a superior mediastinum, anterior mediastinum, middle mediastinum, and posterior mediastinum. Now, you need to know which are the tumors which are common in each part of this mediastinum, and then we'll talk about thymomas and mediastinal germ cell tumors in a bit of detail. So superior mediastinum, what all can you get there? You can get a retrosternal goiter, right? We've already covered retrosternal goiters in great detail in the thyroid module. So retrosternal goiters can be seen in the superior mediastinum. We can get a lymphoma and also parathyroid adenomas. Parathyroid adenomas can also be seen in the mediastinum, especially the ones which are familial in nature. You can have multiple parathyroid glands involved, they can be seen in the mediastinum as well. The anterior mediastinum, you can get a thymoma. So anterior mediastinum is very important. The tumors which you can get here or lesions which you can get in anterior mediastinum are thymoma. Thymoma is the most common mediastinal tumor. This question has been asked in the exam many times. And this is what is written in Bailey, and this is what we'll follow, that thymoma is the most common mediastinal tumor. Now, anterior mediastinum, the other things which you can remember, you can get a terrible lymphoma. And you can get a teratoma or a mediastinal germ cell tumor. Or a teratoma also we can get. So 3 T's you can get in the anterior mediastinum. The middle mediastinum, you mainly get cystic lesions in the middle mediastinum. So middle mediastinum, cystic lesions are the most common, and the most common in middle mediastinum, so the most common in middle mediastinum is the pericardial cyst, So this also you should know for the exam. Posterior mediastinum. So posterior mediastinum, we can get mainly neurogenic tumors. So neurogenic tumors, this is very important for your exam. Neurogenic tumors are most common in posterior mediastinum. And if you remember your module on adrenal glands, we discussed that neuroblastomas can arise from the sympathetic chain, which is posteriorly placed. Right, so posterior mediastinum, neurogenic tumors are the most common. And one more question which you can get in the exam, that neurogenic tumors are the most common mediastinal tumors. These are the most common mediastinal tumors in children as well. So these are the most common mediastinal tumors in children. That is another question which has been asked in the exam. So this you should know about. You should also now know about some bit of details regarding thymomas and germ cell tumors. So first let's talk about thymoma. Now thymomas, I told you, are the most common mediastinal masses, most common mediastinal tumor, and this will be seen in the anterior mediastinum. This is going to be seen in the anterior mediastinum. And these thymomas can be associated with myasthenia gravis. They can be associated with myasthenia gravis. And that is why these days this is getting a lot of attention, because in patients with myasthenia gravis, those who are not responding to medicines, a thymectomy helps or improves in disease control. So thymectomy in myasthenia gravis helps in disease control. This is another point which you should know about. A thymectomy helps in the management of myasthenia gravis, and I'm sure this has been covered by Dr. Rakesh in the neurology lectures as well. Now, these thymomas are mostly benign. So, majority of the thymomas are benign in nature. But if there is vascular or capsular invasion, then they can have malignant thymomas as well. So, vascular and capsular invasion can give rise to malignant thymomas. And you should know the Masoka staging for thymomas. This term Masoka has been asked, and in the super specialty exams, the detailed staging has also been asked in the exam. So stage 1 is when macroscopically completely encapsulated lesion and there's no capsular invasion. 2 is when there's macroscopic invasion into surrounding fatty tissue or mediastinal pleura, and microscopic invasion is present as well. 3 is when macroscopic invasion into neighboring structures. 4A is pleural or pericardial dissemination, and 4B is hematogenous spread. Now we have to carry out a thymectomy, and if it is a small lesion, we can go via the transcervical route. If it is a small lesion, we can go via the transcervical route. So transcervical route can be done for smaller lesions, but if it is a large lesion, then we have to carry out a thoracotomy. And we have to then remove the lesion. The final thing which you need to know is regarding mediastinal germ cell tumors. Now, whenever we talk about mediastinal germ cell tumors, the name which pops into mind is Yuvraj Singh. So you know that Yuvraj Singh, while playing the World Cup, was having a mediastinal germ cell tumor, and he used to throw up after every match. And ultimately, this mediastinal GCT was detected in him, and he had to undergo chemotherapy as well. Mediastinum is the most common extragonadal site. It is the most common extragonadal site for germ cell tumors. It is more common in males as compared to females, and this is usually seen in the anterior mediastinum. Now, benign lesions, majority, 75% lesions are benign, and this is known as a teratoma. But in malignant lesions, in malignant lesions, the tumor markers will be raised. And we know the tumor markers, we've discussed this in testicular cancer as well. Alpha fetoprotein, beta HCG, and LDH can be raised if it is a malignant germ cell lesion. And the management of these patients is excision. And if it is malignant, we have to give chemotherapy as well in these patients. So this was regarding mediastinal tumors, and I told you in the last 3 years, lots of MCQs have been asked regarding this. One more minor topic before we end this module, that is sequestration of lung tissue. Now, sequestration of lung tissue means when some portion of the lung, is receiving blood from an aberrant vessel, arising from the thoracic aorta. So this is an embryonic problem where some amount of tissue has been sequestered, and this tissue is receiving blood from an aberrant vessel but which is coming from the thoracic aorta only. So it can be intralobar sequestration or extralobar sequestration. Intralobar, left is more common as right, and this mainly involves the lower lobes, and the blood supply comes from the descending thoracic aorta. Extralobar is when left side is more commonly involved as compared to the right side, and again the thoracic aorta is the blood supply. So this brings us to the end of this module. For final year students, from this module, you should know about pneumothorax, which I've already covered in traumatic pneumothorax and tension pneumothorax. Other than that, nothing else has been asked as short notes in your college exams from this module, but it is a very important module from the point of view of MCQs. Let's just do a few MCQs before we end the module. Blood supply from intralobar sequestration, I just told you, comes from the thoracic aorta. Which of the following is an immune-mediated paraneoplastic syndrome? Now, we know that paraneoplastic syndromes are more common in small cell lung cancer, and an immune-mediated one is peripheral neuropathy. That is an immune-mediated paraneoplastic syndrome. Massive hemoptysis is defined as more than 600 cc of blood in 24 hours. That this mainly occurs because of tumors and secondary to cavities which can form in tuberculosis as well. Coronary grafting, this I've already shown you in the arterial module, is taken from the saphenous vein. I even showed you a video of how a saphenous vein graft is harvested. The only exception to this is Lima-Ladd. So for left anterior descending artery, we use a left internal mammary artery graft. Internal mammary artery graft is used. This is the only exception. This you should know, Lima-Ladd. Otherwise, for all of them, the saphenous vein is used. So that brings us to the end of this module on thorax and mediastinal tumors.